Afternoon, everyone. My name is Martina Penazzato. I'm the pediatric HIV lead in WHO Geneva. And together with all my colleagues on the line, I would like to welcome you all for this other session as part of the pediatric and adolescent series that we've had for a number of months now on the ECHO platform. Today, in particular, we have the pleasure to host this webinar in collaboration with our colleagues in UNICEF and PATA. And so you'll hear from some of them later on during the course of the webinar. Today, we will start the new year really talking about a very important topic, which is identifying infant children and adolescents with HIV, which we know it's really the key first step to really be able to provide HIV services to this population. Before we get into the topic of discussion today, I want to note that the webinar will be translated into French and Portuguese, and these are some instructions to activate the simultaneous translation, as you can see here. Also, if you have any problem with the platform, please contact our colleagues in ECHO and just really interact with them in order to resolve any problem that might arise. One other important element is that these webinar is being recorded, and with your attendance, you are providing consent to be recorded. We know we have collected a number of information about yourself, and we'll keep them for confidential, and we'll only use it for the purpose of this webinar itself. Also important to note that a certificate of attendance will be provided to you shortly after the webinar, after filling a survey that you will receive. So I want to start by reminding you that these webinars were initiated really with the idea of continuing a dynamic and interactive dialogue with country programs in trying to really scale up HIV services for children and adolescents, and in trying to promote and foster collaboration and South-to-South learning. Together with the opportunity to provide updates from WHO, but also from other key partners that are really active in supporting HIV services scale up for this population. We've in fact built on previous work that we've done together to really expand the reach of this platform and ensure that many of you on the ground can really connect over this platform and really interact with us on any specific issue that may trigger technical assistance. So the overall objectives of this webinar are really to provide information and to enable interactive discussion. And so the overall goal is really to flag challenges, share solutions, and trigger, as I mentioned, technical assistance by various stakeholders that are connected on this platform. We need to remember that despite progress and the reduction on the new infections in children over time, we still have more than 400 children acquiring HIV infection every day. We know infection is acquired perinatally, but also postnatally. And you can see that about 50% transmission it's expected to occur postnatally. And obviously this is relevant for the diagnosis of HIV because it reminds us that one time point might not be enough to identify all children living with HIV. We also need to acknowledge that while there's been a lot of progress on scaling up the ID services, we are not there yet. We have many countries where coverage remains still unacceptably low, and where new solutions need to be put in place to ensure that children are identified in a timely manner. We also need to acknowledge that a group proportion of the population of children that we need to serve is actually above 5 years of age. And indeed, this is an important element that should help us to reflect on our testing strategies and acknowledge that infant diagnosis does not allow us to identify all children that are out there. And we need to think about how to combine various testing strategies to ensure that we can identify all children living with HIV. So we need to start from the early days by implementing the infant testing algorithm that was updated in 2018, and my colleague Lara and a few other colleagues on the line will help us to think through some of these specific elements of the algorithm and reflect on their implementation at a country level. And so we need to remember that this is really not one-time process, but it's really something that needs to be done over time and implemented in a reliable manner. We also know that case funding remain a core element of any testing strategy for infants, children, and adolescents. And in that sense, we need to remember that those children are getting sick, in particular those that access facilities, inpatient services, nutrition services, are really those that should be considered for HIV testing, and that's where we can really maximize our opportunity to identify children that present sick. We also know there are other entry points that may be less efficient in terms of identifying children. And we know that those strategies might need to be tailored to the epidemic context that we have in a given country. And that's why WHO has worked with partners to develop a strategy decision tool that is available on the H3 toolkit and that you can play with by reflecting on your specific country characteristics and find some guidance on where resources might be better used in order to maximize the opportunity to identify infants in the various entry points. We also know that when children become older, as we mentioned earlier, we really need to think about other testing strategies. And certainly over the last few years, it's been very critical to ensure that we scale up family-based testing or index case testing, as we've mentioned, because we know that this is an approach that can really maximize our opportunity to identify children that live with HIV. So today we'll touch on many of these elements with country perspectives, with reflection, and with experiences from various countries in sub-Saharan Africa. And so we really hope to be able to engage with you in an interactive conversation through the various question and answer session and throughout the webinar today. So without further ado, I want to hand over to the next session to my colleagues, Cheryl Johnson, a focal point for HIV testing in WHO Geneva, and then to Lara Voinov, diagnostic advisor, again, for WHO Geneva. So over to you, Cheryl and Lara, and I'll stop sharing my screen.
Excellent. I'm delighted to follow up from that great presentation from Martina and talk to you a little bit about a summary of our guidance when it comes to testing children over 18 months. So I'll really in this presentation walk through a little bit of the latest guidance that was released at the end of 2019 around testing and specifically for high HIV burden settings. I'll clarify some of the existing guidance, especially for kids, about what we can be doing on who can do that testing and the role of lay providers. And then as kind of noted, some updates related to risk screening tools and our testing strategy in terms of the 3-test strategy we've had in the 2019 guidelines. So Martina's really highlighted one of the key aspects of our guidance for children, that in facility settings, it's important for us to be focused and really ensuring that we're getting access to testing in these key entry points, for our high HIV burden settings. And as Martina highlighted, really for specific malnutrition clinics and inpatient clinics, and most recently that our really nice article by her and colleagues that really does highlight the benefits for immunization clinics as well. And when it comes to community-based testing for children, it's also very important for us to be focused. So sometimes when we're trying to think about the best way to do our outreach, the family-based testing and index might be really critical because broad community-based testing for all populations may not necessarily be so strategic. So in our guidance, we focus on ensuring we have testing for community-based settings when it's really focused for key populations, but also filling in gaps related to that facility-based system. So one of the key approaches that can take place for reaching children in facilities and communities is this provider-assisted referral. And often in this space with reaching kids, it's family testing or index testing or even assisted partner notification that we might be calling it, where it's important that we're offering this package to all people with HIV and really ensuring that we're getting testing access for biological children of people with HIV. So really important that this takes place. And I'm just showing you in this bar chart that in general, we see most of the time these services being implemented in facilities, but communities are definitely a place where we could be doing much more follow-up for family-based testing or index testing. And across the community, the facility, and the index testing approaches, wherever that may take place, lay providers are essential to the work of reaching children. So in 2015, we recommended that lay providers can do rapid diagnostic tests. And this is such a key part of our scale up and increasing access for children. And so I think it's really important to ensure that we're utilizing this as much as possible in our programs to extend the reach. And when it comes to the testing strategy, this is the latest testing strategy we released in 2019 to simplify our testing and diagnosis. And again, this is for children over 18 months. And I know there will be more detail for early infant diagnosis after this. But in this testing strategy, in all settings, we would be doing 3 consecutive reactive tests to provide a positive diagnosis. And you can kind of see just the order in which we would do those tests. We would only repeat the first test to resolve a discrepant result, and we would really be using this strategy to help us as we see more and more countries getting closer to the first 95 and better targeted testing programs, that this will be really the strategy to employ globally for HIV positive diagnoses moving forward. And so very happy to answer questions about this if this is new to your program. And one thing that I will flag here is that this testing strategy is really populated with rapid diagnostic tests or enzyme immunoassays. So that's the testing strategy we would be doing for children over 18 months. And this strategy with the combination of those tests, and there's a list I've included in this slide from PQ, but just to note, all those products that we list would have at least 99% sensitivity and at least 98% specificity. And using them together in this strategy, we would be able to achieve that 99% positive predictive value, which is so critical to effective diagnosis. Now, we often get a lot of questions too about different strategies in the community when we're trying to do testing. Maybe we can't do all 3 tests when we're just doing the outreach in the community setting. So WHO does have guidance around this, and we recommend that tests for triage. So this is where a trained health worker or lay provider can use a single rapid test, either an oral or a blood-based test in the community. And those were the reactive tests. So kids with that reactive test would get confirmation at a second site, like a facility, or even if there was other programs in the community that could be utilized as well. But those who would have a negative result, they would definitely be counted as negative and referred to those relevant prevention services as needed. So this is an advantage to think about for some of those strategies of, well, where do we start if we want to scale up community outreach or some of our index testing programs? Maybe there's a role for tests for triage. And sometimes we get the question, whether this testing can be performed by caregivers or if people can be using self-tests around children. And so one thing we're really clear on in our guidance is that children under the age of consent are not able to self-test. And currently caregiver testing is not recommended by WHO. We know of some ongoing research and we're really excited to review that. But at this juncture, we really advise that this is more of a community-based testing approach where we can kind of expand our reach, really support those index testing programs. But that right now, the test for triage would really involve health workers or lay providers. And really, just to recap, I think we really would see that the best way forward is this mix of facility and community testing, really prioritizing that index testing, utilize trained lay providers, and reiterating that when it comes to the test kits available, there are so many great choices. Rapid tests for reaching kids, we have oral products and blood-based products that could be really applicable to your setting, or or innovations that you might want to start to increase access. And just as a note, yes, we are recommending a 3-test strategy to provide, really accurate diagnosis to support our treat all recommendations. But there's also community outreach like test for triage approaches that could really help scale up in smaller communities as a good first step, or just as a way to expand your broader program. I did want to highlight that as we look across our data that's reported here at WHO, there is a significant need for testing kids, and we see that our positivity and total tests could be further optimized, especially when we looked at our 2019 data. And I know, although I'm not showing 2020 data, we would assume the same. And a lot of programs are thinking about how to optimize. So the question has really been around risk-based screening tools. So for these risk-based screening tools, these can be electronic or paper-based, self-reported by a client, using clinical records, administered by providers. They can also use a combination of different demographics, symptoms, testing history, indicator conditions. And one of the defining things we've really talked about at WHO with risk-based screening tools is how they could be used to either screen in, reach people who wouldn't be tested otherwise, or screen out, excluding people who would have otherwise be offered testing. And this is just recapping to you a recent summary from our systematic review that we completed at the end of last year. There's so much to dig into in this table, and I don't think we'll have too much time on that. And there's going to be some great presentations later in this session. But one of the primary tools we've seen a lot is this tool for screening in that's really been helpful in different settings when it came to folks having been admitted to the hospital, recurrent skin problems, one or both parents deceased, or having poor health. And this tool we've seen adapted in many different studies. And really, just to give you the synthesis or the outcome of our systematic review and meeting last year, in the end, what we've really seen is that our screening tools, we have to be very cautious about their use when it comes to screening out individuals, because we might miss people who should be tested. So that's a very a big concern that we continue to have, but we do see the benefits of screening in. So in settings where those that might be missed or who would not be offered testing otherwise, such as sick children and those with other risks and symptoms, there's a potential benefit of screening tools to help really prompt providers to offer a test when they might have missed otherwise. There's some additional optimization on screening tools that pertain to adults that I've just included in the slide for background, which we won't dig into today. But I think that continues to be something where we will look at these tools. It is so critical for any program thinking about screening tools for children to ensure that there's something validated before we even really start to have that discussion. But I think at this stage, we see potential benefits for those that are screening in and reaching those who would otherwise be missed. If there's any questions, please contact me. I'm available. But that's really all that I wanted to highlight to you today, and just hand over to my colleague, Laura.
Great. Thank you so much, Cheryl. I'll just begin to share my screen. And today I'm going to talk a little bit about some of the new considerations that we have in infant diagnosis, and that would be primarily then infants less than 18 months of age. And as Martina nicely highlighted, I think some of the key considerations that we've been thinking about of late is really how we can increase access to testing. So number one, finding those infants who we haven't been testing already. And that's where some of those entry point conversations are coming, as well as, of course, continuing some of the traditional testing that we've been doing thus far. But one of the key pieces that you can see from this slide is that we still see quite a significant gap in terms of the total coverage of those who are in need of an infant diagnosis. And so really trying to think through how we can try and maximize and what tools can be used to try and increase access to testing. And Martina highlighted just very quickly the algorithm that we worked on in 2018 and made a few adjustments based on recent interventions and evidence that came about. And some of the key components that we really want to touch on is number one, that infant testing is really a process. Previously and at times and in some settings, There's been a lot of focus on the 6-week infant diagnosis test, and of course that's really important, but we really also want to move towards a multi-test algorithm. So that includes birth and in those places where it's of value, and I know we'll have a couple of speakers later presenting some of their perspectives on that. Of course, still maintaining that 6-week test. Also, we've made some adjustments to the 9-month test that was previously recommended, and now suggesting that it be done using a nucleic acid test, especially as availability of those tests have expanded quite considerably. And then anytime there's an HIV exposed infant that presents sick. There are also, as Martina hinted at, some really important considerations for routine testing of those infants who are presenting to malnutrition, tuberculosis, and inpatient wards. And those aren't necessarily known HIV exposed kids, but of course you can determine their exposure through testing their mom at those sites and then entering them into this algorithm where necessary. Another key component is that we really want to encourage confirmatory testing of anyone who has a positive nucleic acid test. And that's of course to make sure that we're putting those infants onto treatment correctly. And they should be put onto treatment after a first positive test while we're confirming that. And then finally, really importantly, is that diagnosis shouldn't be considered complete without that final diagnosis at the end of the period of the transmission risk. And this should happen either at 18 months of age, at which point we can start using serology, or 3 months after cessation of breastfeeding, whichever is later. And so really encouraging consideration of all of these different components to maximize identification of infants. In 2018, we also recommended an indeterminate range be considered, and this can primarily be done in the lab or wherever the testing is done. And this is because the qualitative tests that we use generally report detected or not detected, and that's immediately usually interpreted as positive or negative. But we know that in cases where there's perhaps really little virus in the sample, it might not actually be due to infection, but lower positive predictive values. And this is something we see with all diagnostics, no matter how good the performance is. And similar, as Cheryl was just mentioning, why we're moving, for example, to a 3-test algorithm for HIV testing is we really want to ensure that those that we're diagnosing are correct and putting onto lifelong treatment. So we really suggest identifying and repeat testing samples that have low-level viremia effectively by introducing an indeterminate range that can minimize unnecessary treatment initiation. Another key component that we've been reviewing, and this is something that we reviewed in the fall of last year, and so we're still awaiting final approvals, but hopefully updated recommendations will be with you shortly, is that though we have a number of technologies that are available, we've started to see really increased access to 50–60% of infants receiving an infant diagnosis within the first 2 months of age. We're seeing considerable delays in when those results are actually returned to the facility and returned to the caregiver. And a systematic review that was done for our guidelines suggested that though a number of caregivers received the results, about 77%, the mean age at testing was 74 days, which does align somewhat well with that 6-week testing suggestion. But the mean age at treatment initiation was considerably later than that. It was about 7 months after the test sample was collected. And this really indicates those challenges that we've seen with sample transportation to a lab, testing in the lab, the result being returned, and then the mom and the baby coming back to receive that result, treatment being initiated. And unfortunately, what we saw in the systematic review is that about 15% of positive infants have died between receiving that sample being collected and starting onto treatment. So there are some solutions to perhaps maximize this cascade. And one of those that's been discussed quite a bit in the last few years is point-of-care infant testing. There are a number of studies that have now reviewed the clinical impact of point-of-care testing compared to lab-based testing. And a few really interesting things came out of this separate systematic review for our guidelines. And that's number one, that infants were 8 times more likely to start treatment within 60 days when they were given same-day point-of-care testing compared to a lab-based test. And that was about 93% started within 60 days compared to only 50% with standard of care. Generally, because of that, we saw that the time to initiation was actually 0 days. Most kids were put onto treatment that same day as that positive result, whereas that was considerably lower. It was about 40 days. It took 40 days for lab-based testing. And of course, there was no ability for the most part for infants to be put onto treatment on the same day as their sample was collected with lab-based testing, whereas, like I said, over 50% were. Of course, another key important criteria and consideration for these types of technologies in order to be able to provide same-day testing is that they are a little bit more expensive than the lab-based testing. Though that is, and a number of partners are trying to work towards better pricing, more transparent, all-inclusive pricing to really bring some of those costs down to a little bit closer price parity to lab-based testing. So there were some cost-effectiveness analyses that have been published to date looking at the cost effectiveness of point of care testing compared to lab-based. One of the key things, as I was just indicating, is that there are a lot more infants that do get initiated onto ART within 60 days with point of care testing versus standard of care. Essentially, the costs of the program look like they're about $966 per additional ART initiation, and that's if the infant diagnosis program bore all of the costs. Of course, we know that's not always the case, and it's not always what's being done in a lot of sites. There are a number of countries that are utilizing point of care technologies that have already been procured through other programs, such as Gene Experts through the TB programs. And considering that sort of integration really reduces the overall costs to being quite a bit more cost effective at about $268 then. And in some cases, even potentially cost savings, because you can imagine that those programs working together, integrating not just the device, but the HR, the service and maintenance, really can support each other in bringing down costs and creating a more efficient network. And we'll touch on that a little bit more in the future. Of course, we also want to understand whether this cost effectiveness analyses translated into actual affordability in countries. And this was an analysis done by Chai, again, for our guideline process, where we wanted to see, and I believe this was done in 4 countries, what the reality of implementing point of care to a large proportion of the patients who were in these countries. We know that number one, there are a number of countries that have already started implementing point of care infant diagnosis. And number two, it's also relatively clear from some of the data that infants tend to focus in a small number of healthcare facilities. So a small number of those sites actually serve the majority of those populations. And then we have what we call a very long tail of thousands or hundreds of sites that perhaps only see 1 or 2 infants a year. So in order to provide point of care infant testing to either 70%, 80%, or 90% of infants, essentially what you see, and of course you would supplement the remainder of those needs with the laboratory-based testing. You see that the incremental cost increase is relatively similar between the 2 different technologies and goes anywhere from about $300 to $600, depending on the level of access you're looking for. But one of the key points I think that is really important from this, and obviously countries would want to think about sort of what their sweet spot is in terms of affordability, really is the number of infants, additional infants that would be initiated across these 4 countries. And important to note that in trying to implement 90% of same-day point of care testing, you can get to an additional 65,000 infants being put onto treatment. We also wanted to look into what perhaps some of the values and preferences were from people living with HIV, and they were quite interesting. We also looked into those from health workers, from program managers, and for the most part, they were relatively positive across the board. I just have 2 quick snapshots here showing, for example, that people living with HIV, and those were primarily caregivers, did feel very confident for the most part in that healthcare workers could perform point of care infant diagnosis and start treatment quickly. But also most importantly, it was very clear for them as well, even if they didn't have access to point of care infant diagnosis or hadn't yet been able to use it, for the most part on this right-hand graph, they did see the benefits in that clinical improvement for infants, in that more infants, more babies would be started on ART, on treatment, and that perhaps also more infants would remain in care. There are also some interesting quotes from some of the people living with HIV, indicating and suggesting having some peace of mind, for example, taking away their anxiousness, their frustration, and really just having more trust in the timing of the results being provided, and that they could move forward and take the next steps and the right steps in being able to provide support to their infants, whether positive or negative. But of course, we also want to reflect on some of the key implementation considerations with this type of a technology. We're not yet at the point of having a device-free rapid diagnostic test for infants that can be used, still testing for nucleic acids. And so there is that consideration that we do still need to expand our diagnostic testing. I think currently over the last year, we've really seen that quite a bit with COVID, the need to really think through how we can optimize our systems, how we can combine lab-based testing with point-of-care technologies in a more integrated network. And ideally, we would do this within HIV, but also with other disease programs to create some of those efficiencies that I spoke about. And that includes tuberculosis, HIV viral load, but of course, hopefully and ideally starting to expand to other diseases like hepatitis, STIs, and emerging infections. Of course, implementation of point-of-care infant diagnosis does require and ensure adequate human resources are available, training and consistent monitoring and evaluation, mentorship, service and maintenance, and of course, quality assurance. It's also important to note the considerations for people living with HIV as well, and that we need to ensure clear messaging and communication and literacy considerations in order to support that trust and utilization. And really, they need to, ideally step up and demand those tests as well in order to support their infants. And then finally, it's always great to have as many tools on the infant diagnosis piece as possible, but those tools are only as good as ensuring that we put and strengthen treatment services and care services for infants and children. Ideally, all of those who are found to be positive would be linked to treatment and then supported thereafter to be maintained and ideally virally suppressed. Another couple of questions that we looked at, in particular, is what we call diagnostic integration. And this is starting to think about technologies that can test for more than just one analyte, whether it's hepatitis, HIV infant diagnosis, viral load, tuberculosis, HPV, and we can go on and on. There are a number of technologies, as you can see in the bottom right-hand box here, that are currently offering a suite of different tests and different disease analytes on those products. And ideally, what we would do is rather than buy one of each for every single disease or every test that we would utilize, we'd start having the conversations about creating diagnostic optimization. There are a couple of documents that have already been released by WHO and others that go into the landscape of what's available, some of the key considerations and some of the details around creating those optimized and more efficient systems. And then finally, I just want to leave you on a couple of documents that we've spoken about a little bit. These two are from 2018, looking at some updated guidance as well as some programmatic considerations. And then the recent guidelines that we had that touched on both clinical and service delivery questions, including a number of diagnostic questions that I've gone over, as well as a couple of more looking at viral load and treatment monitoring. We're hoping should come out relatively soon over the next couple of months. And of course, we're happy to share those as those are becoming available. So I just want to thank you all for listening and pass it back to Martina.
Thank you very much, Lara and Cheryl. Really comprehensive review. I know there is a number of questions that have come up on the Q&A, and we'd like to invite colleagues to continue to include their question in the Q&A function, and our speakers will try to address them as quickly as possible. I believe that we might have a bit of time for any specific question. I see there are a few that have come up on the line that have already been addressed. I know that there is a good one that I just caught my eye that relates to how we can learn from the COVID work and really find and use the technologies and the approaches that have been used for COVID to really improve EID. And Lara, maybe this is particularly for you. Candice Green saying, if COVID results can be sent via SMS by lab to all patients, why can we not start this for infant testing and get the results to the caregiver? So I wonder whether you'd like to make any comment on that.
Sure, happy to do so. And this has actually been an interesting one that we've looked at in the past, primarily thinking about SMS printers, where the test results go from the lab to the healthcare facility. That seems to have reduced that turnaround time. And actually that's where those 45 days generally are using SMS printers to expedite what was an even longer cascade. That said, of course, the next step is ideally, whether it comes from the lab directly or goes from the lab to a healthcare worker, is then those results going to the patient. And I think that's certainly something that is a conversation, and we'd like to see some of the evidence, some of the data behind that in order to support consideration there. Of course, there are also some other issues that we want to ensure, such as, for example, making sure that linkage to care happens thereafter for those that are positive, and that for those that are negative, they understand the need to come back to fulfill that testing algorithm that we went through. Of course, though, it's also important to note that that option and that intervention may not manage and may not shorten some of the other key components of the cascade, such as the sample collection, sample transportation time to the lab, the time in the lab. And so one of the things we do want to understand is really what is the shortest time that makes sense in terms of providing that clinical impact. At this point, we've seen the same day providing the best clinical impact, being able to initiate the most infants and capture the most positive infants. But I think we'd like to also understand what other interventions like you're suggesting might be able to help.
Thanks, Lara. So in the interest of time, I see lots of questions on point of care, which we'll come back to in the next session. There were also some good questions that I believe Cheryl has already addressed. So we'll keep an eye on your question on the Q&A and try to address them more specifically. Maybe an overarching comment related to WHO guidelines that Lara sort of mentioned earlier. We expect updates coming up in this month, towards the end of this month, that relates specifically to infant diagnosis and the use of point of care, which Lara mentioned. We also expect to be able to launch a revised ARV consolidated guidelines in July. And so a few items related to infant testing and pediatric testing in general will be captured in the more extensive guidelines. So with that, I'll stop there and hand over maybe to Fausta for facilitating the next session.
Thank you, Martina. Good afternoon, good morning, colleagues. I would like first to start by reminding each other, and we have all been working very closely after our 2018 recommendations guidelines came out, and these have been done through different technical working groups. Some countries are having pediatric technical working groups specific. Some are combining with lab technical working groups. So this is an opportunity to listen and also to from our colleagues from few of the countries that who have agreed to share with us, and I'd like to thank them. But before I proceed, I would like to request our three panelists to introduce themselves as the way they would like me to pronounce their names. We can start with Angela, and then Kanchana and Joseph. Please introduce your name and what you're doing. Thank you.
Hello, everyone. This is Angela Mushavi. I'm the National PMTCT and Pediatric HIV Care and Treatment Coordinator in the Ministry of Health and Child Care in Zimbabwe. So you can just call me Angela.
Good morning and good afternoon. This is Joseph Bango. I am the Acting Deputy Director in the Ministry of Health in Malawi, responsible for laboratory services. You can also call me Joseph. Thank you.
Hi, everyone. I'm Kanchana Sugu. I work for the Clinton Health Access Initiative, and I'm the Director for Pediatric HIV on CHAI's HIV Access Program. You can call me Kanchana. Thank you.
Thank you very much. And I'm Fausta Mosha. I'm Lab Technical Officer working for WHO Africa region. I'm based in Zimbabwe. So I would like to start with Angela. Can you give us experience on birth testing and how it has been happening in Zimbabwe? But meanwhile, please, colleagues, you can continue to write your questions in the chat box, and we'll, the presenters will be responding as we continue. Angela, over to you.
Thank you, Shakiwa, and greetings to all on the call. Zimbabwe received some support from UNITED, quite substantial, over the last 5-6 years for implementation of point-of-care diagnostics. And as part of the implementation of that grant, which was through CHAI, UNICEF, and EGPAF, several papers and publications have come out regarding the utility of point-of-care testing. We took advantage of that grant to deploy birth testing, and our birth testing algorithm in the 2 central hospitals was for high-risk HIV-exposed infants. And how we defined that was if maternal viral load was greater than 1,000 copies at 36 weeks, those infants would be stratified as high risk. We found, though, that only 36% of moms had a viral load that we could utilize. So we used proxies to determine who was a high-risk infant. So if the mother started ART late, 8 weeks before delivery, if she was clinically stage 3 or 4 WHO, and if she had an incident infection, then we use those as proxies to define what a high-risk exposed infant. And that was a study done in 2 central hospitals of Harare and Parere-Nyatwa with support from CHAI and UNICEF. The other study enrolled infants, whether they were high risk or not high risk, they were enrolled into birth testing, and this study was supported by EGPAF working with the Ministry of Health and Child Care. And the results are promising in the sense that for the high risk exposed infants, there was very high acceptability by parents of having an EID at birth. In both central hospitals and district hospitals. The district hospitals used a hub and spoke model to collect results. So what we found was the babies that were tested at birth and tested positive were quickly initiated on ART. The positivity was around 1.5%. And yet we know from our modeling estimates, the final HIV transmission is 7.78% or 8% for Zimbabwe, which means quite a substantial number of postnatal transmissions occur. In the hub and spoke sites, where both high risk exposed and low risk exposed infants were being tested, positivity was 1.5% in the low risk exposed infant, and it was 6.5% in the high risk exposed infants. So there's a benefit in stratifying who needs to have early infant diagnosis or a nucleic acid test at birth. This is our experience. What we then found in the sites that were only confining themselves to the high risk exposed infants, even mothers who did not have high-risk exposed infants, they also wanted their babies to be tested. We found that turnaround time was quite reduced from 0 to 7 days, where we had point-of-care machines. And then we found it impractical to utilize conventional machines at the moment because of the high turnaround time of results for EID, which is ranging anywhere from 28 days to 69 days. So traditionally and realistically, if it is birth testing, you should be able to get results timely and then link the HIV-infected infants to care and treatment. Linkage was very high in the sites that had birth testing, and healthcare workers needed quite a bit of training for them to be able to initiate infants on it. So there are advantages to birth testing. At the moment, the country is not having routine birth testing for all in all of the different facilities that are almost like 1,600 sites. We have found it very useful in sites with POC machines, and now we are considering how we can roll that out to sites that do not have POC machines. In terms of the challenge, the babies who test negative at birth, the 6-week testing should be reinforced. And we found in the central hospital that 2/3 of babies did not come back for 6-week testing, probably because they go back to their referral facilities, they go back to primary care facilities. We also found that healthcare worker sensitization might not have been adequate because some healthcare workers then turned away mothers who had brought in their babies for 6-week retesting if the infant tested negative at birth. So we still need to strengthen the 6-week platform, and we need mothers and healthcare workers to be aware that birth testing does not obviate the need for 6-week testing. I don't know if I've overrun my time, Shakiwa.
Thank you very much, Angela. It's a very good experience that you've shared with us, especially in terms of birth testing. It's okay, we can, if you are done, we can invite Kanchana to continue.
Yes, please.
Okay.
I think that would be useful. My only last comment was the costs and the sustainability aspect for point of care post-UNITAID support, because we then had to look at PEPFAR, the Global Fund, and country resources to continue utilizing these point of care machines. So I think the slide on cost effectiveness that was presented is very useful. How do we continue to strengthen point of care testing so that we have timely results and timely linkage to care and treatment? Thank you very much. Over.
Thank you very much, Angela. And now I would like to, please continue to write your questions on the chat, colleagues. Now I would like to invite Kanchana for taking us through experience on 9 months and final testing. Over to you, Kanchana.
Thank you. Thank you so much, Fausta. Can you see my screen?
Yes.
Okay, great. So I thought I would talk a little bit before going into the specific experience, just do a little bit of scene setting by showing how many countries have adopted the 9-month NAT. So as you can see in this slide here, 2 years since the new WHO guidelines, 3 of the 7 CHI program countries that we looked at have adopted the 9-month testing. 2 countries haven't really updated their national guidelines since the 2018 WHO update. So there's still opportunity to align more closely with the WHO guidelines. For final testing guidelines, however, as you can see, almost all countries really closely mirror the WHO recommendations. So I would now like to just talk a little bit about country experience from 2 countries on the rollout of 9-month testing. The first one that I will talk about is Uganda. So overall, in the countries that have implemented 9-month testing, what we are seeing is that implementation is feasible and can actually be an important point, time point for identification and initiation on treatment. So in Uganda, 9-month PCR was rolled out at the end of 2019, along with mentorship and revision to the registers. While there were some challenges initially, these were addressed through really close mentorship, updating the registers, line listing of mother-infant pairs, and to make sure that there was follow-up, and to make sure that those who have defaulted are brought back into the system. As a result, we're starting to see 9-month PCR coverage go up, and specifically in the unfinished business districts that CHAI, along with other partners, support, we are seeing coverage as high as 80% for the 9-month testing. As you can see in this chart on the left for Uganda, almost 13% of all HIV positive infants are now being identified at the 9-month testing point in Uganda. This number was close to 25% at the end of last year. So all this just to say that this is an important strategy to identify HIV positive infants. Moving on to Zambia, it's a similar experience. 9-month testing was rolled out in 2019, and between 2019 and 2020, we are starting to see a significant increase in testing volume. In Zambia too, similar to Uganda, about 14% of all HIV positive infants are now being identified at 9 months, and some factors that contributed to smooth implementation in Zambia was really very clear guidance from the Ministry of Health in the form of a memo, additional trainings and mentorships, and a really good coordination amongst various partners involved to ensure that implementation went well. Having said that, I think the rollout hasn't come out, it hasn't gone without challenges. In countries where 9-month PCR is being implemented, some of the challenges that we are hearing most frequently is around documentation and reporting, is around sample transport challenges, as well as really keeping mothers engaged in the system and tracking mother-infant pairs. Even though 9-month testing coverage is improving in countries that are rolling this out, that number drops significantly when it comes to the end of breastfeeding or the final testing. So across all of the countries, we are starting to see some opportunities to improve both 9-month testing and the final testing. So number one, we definitely have a long way to go, but one opportunity that we see is really important is longitudinal follow-up using electronic mother-infant pair tracking systems and automated reminders for mothers. In some of our program countries under the FASTER project, we are really working with ministries to improve electronic tracking, which we hope will increase the coverage of both the 9-month testing as well as the final testing. Number two is alternative entry point screening. Both Martina and Lara mentioned this during their intro remarks, and we think that this can certainly help identify infants who have been missed. The work that we did in Uganda a couple of years ago showed that almost 56% of positive infants were identified in additional entry points such as nutrition, inpatient, outpatient wards, etc. So this demonstrates that it is a critical strategy to improve coverage at additional testing time points. Number three would really be around the inclusion of 9-month testing point in cohort monitoring registers. We found that countries that have updated registers and are actively testing coverage at this time point are also showing improvements in uptake. And then finally, this was mentioned, and I will emphasize again, is that engagement of communities and demand generation work can certainly improve coverage for both 9-month testing as well as final testing. So I will stop there and hand back to you, Fausta. And I'll just wrap up by saying That's definitely a long way to go, but our experience over the last 2 years is certainly demonstrating that this is feasible as well as potentially effective. Thank you.
Thank you very much, Kanchana. And I would like to request Kanchana and Angela to go through the questions that already been raised in the Q&A, and then I'll give you an opportunity to respond after we hear experience from Joseph from Malawi on opportunities and challenges in implementing point-of-care infant diagnosis technologies. Welcome, Joseph.
Thank you so much, Shakira, for the opportunity that you have given me. Malawi, just like any other Southern African countries, I think we have made a very good, significant strides as far as EID diagnostics is concerned. I think with the support from CHAI, as mentioned by Angela, and some implementing partners, able to move on and improve in the diagnostic services of early infant diagnostics. Previously, I think we used to do our diagnostics in the 10 molecular laboratories that we have throughout the country. But however, I think as we were doing that, we had a lot of challenges in terms of TAT. I think it was extremely bad. I think sometimes it could go up to 24 days or 30 days. And again, because of the schedules in transporting our viral load samples to these respective NAT laboratories, I think we had some delays as well. So with the support from UNTAD and CHAI, the country had to change its policy on EID testing. I think we moved on to POCs. One of the issues was integrating our services. We used the gene experts, which are throughout the country, districts in Malawi, so that we can reduce the TAT time and issues to do with the transportation of samples. And indeed, I think we have made good progress and the country is doing quite well. A lot of samples are being now tested in the gene expert throughout the districts. And we have even moved into MPIMA as well, about MPIMA, which are also even situated in the health centers in the majority of our countries here in Malawi. And this has resulted in the reduction of TATs in Malawi. And we have even made some health centers as hubs for other sites that samples are being collected in such a way that I think we have actually seen a reduced in TAT, and even the results have been delivered on time. So I think as a country, I think we have benefited quite a lot as we using the POC as a result of reduction in TAT, which I've already mentioned. And we have been able to increase the POCs in various health centers in our country to such an extent that services are now available to many people. Apart from the EID, we have also used these POCs as already alluded to by the presentation that has come forth. We are able to do other tests on the FRSM, the viral load tests.
Joseph? Hello, Joseph. I think we've lost Joseph, but while we are waiting for him, I would like to thank Mungati from Lesotho, who shared the Lesotho experience. We can read it through the Q&A. And quickly, Angela, can you just respond quickly on the question on birth testing? Over to you.
Thank you, Shakiwa. When I was looking at the question and answer section, I think the query was mostly on criteria for birth testing. I tried to type in a response. In the first instance, when we started in the central hospitals, we were stratifying infants and only offering birth PCR to high-risk HIV exposed. In the districts and primary health care facilities where we did try to offer HIV testing at birth only to high-risk exposed, we found a huge demand also from parents of infants who were not stratified as high risk. And so from the publication, testing was then offered to all HIV exposed infants, but this was not in all of the 1,600 facilities countrywide. It was limited to sites that had point of care. The reason for that is if you offer birth testing, and we were defining this as testing between 48 hours and 72 hours, and not between, I mean from birth to about 48 hours or 72 hours. And this would be the time when the mother and the baby are still within the hospital. And with POC, you get the results in the hour. And this was really an excellent opportunity. Now, we could use conventional machines and then open up birth testing, but currently, with challenges with sample transportation and results return, we are finding it difficult to have routine birth testing for all infants nationwide because of the long turnaround time, which can be anything from 4 weeks to as long as sometimes 2 to 3 months. So that's been our challenge. But really, I think there is utility in doing birth testing because what we found in the publications that Martina kindly shared is that mortality increases for infants if they are positive either through intrapartum or early delivery and we miss them. They die before we can make a diagnosis. And therefore, I see a great benefit in rolling out birth testing for all. However, I emphasize that it is important that for the infants that test negative, we should then make sure that 6 weeks, the healthcare workers, the parent, they all know that they need to bring the child back in for testing. And that 6-week return was compromised in some of the sites where we rolled out birth testing. Thank you very much.
Thank you, Angela. Is Joseph back? If not yet, Kanchana, can you respond to a few questions that are directed to you? Over.
Sure. There is one question here on the immunization schedule in Malawi, and I'm curious to learn how the immunization schedule aligns with the EID schedule in Malawi, wondering why 12 and 24 months. That's definitely an interesting question. My understanding is that there is an assumption that breastfeeding or mixed feeding in Malawi goes on for 24 months. So 12 months is considered the midpoint of that period. And so that is the reason why 12-month and 24-month testing time points have been determined. It does not align with an immunization schedule, though.
Thank you, Kanchana. Yes, some of the countries would like to align testing with immunization program so that to make sure that they're getting all the exposed babies, but this can vary from country to country. And also, as Martina also presented, there could also be, apart from that, there could also be different entry points that we might need also to look at. entry points when the baby is brought into the hospital or they're in a nutrition clinics. So at different areas, you find that there could also be important points apart from the routine either birth testing and also the 6 months, or probably waiting for the 9-month testing. So it could also be an opportunity to get the missed babies before it's too late. I don't know if you already have Joseph back. There's also a question for him. If there's anyone from Malawi who would like to respond to a question talking about is Malawi having electronic system to send results to someone mentioned before, and which sample transport system do they use? We could also get experience from Lesotho. They are also using SMS, and also they're using hub and spoke system. I don't know if you have anyone from Malawi who would like to summarize the POC experience before we don't have much time for this session. Anyone from Malawi would like to complement anything? Over. Okay. So I don't see anyone from Malawi, and Joseph is not back. One last word, Angela, 1 minute, and then Kachana 1 minute, and then we end our session. Over to you, Angela.
Yeah, I just wanted to add that the definition of birth PCR and what you do with the result is very critical. If you were to do a birth PCR in the first 48 to 72 hours, and then you had 3 months before you received the result, then it really misses the utility of that test. You would have tested for the sake of testing without actually initiating infants on ART. And then I think basically the other one is reinforcing that we retest. And I had a question where the participant asked if after a negative PCR test at birth or nucleic acid test at birth, we discontinue prophylaxis. No, we don't. We continue because we know there's ongoing risk of postpartum transmission, especially in our communities where more than 97% of our mothers are continuing to breastfeed. So we continue infant prophylaxis. For high-risk exposed, we are using zidovudine and nevirapine for 12 weeks. And then for the low-risk exposed, we are using nevirapine for 6 weeks. So that is our practice. Thanks.
Thank you, Angela. Kanchana, over.
Sure, Foster. Nothing more to add on my end, except maybe to emphasize a point that you mentioned is about the importance of exposure screening in alternative entry points, and how there's really a significant potential in identifying more infants outside of the traditional PMTCT entry points. Back to you, Fausta.
Yeah, thank you very much, Angela, Kanchana, and Joseph. I would like to hand over now back to Martina to guide us on what's next. But I really appreciate your time and your willingness to share experience. And thank you all. Over to you, Martina. Thank you.
Thank you very much, Fausta, and really to all the panelists for the very insightful comments and experiences. So we were supposed to have 10 minutes break. However, we see that there is a lot of interest and a lot of questions. So we'd like to propose to keep going and really move on to the next session, which, as you know, will be focused on family-based index testing. And I'd like with that to hand over to our colleague from UNICEF, Therese Nunduwimana. Apologies, Therese, for not pronouncing your surname well. But over to you, and thank you very much for facilitating this next very important session.
Hi all, actually this is Maggie DiChiara. I'm also in Geneva. And we're having a little bit of difficulty with one of our panelists joining from Cameroon. So we'd like to be able to give him a little bit more time. And so what I might suggest is that we move on and skip ahead to our session on using HIV risk-based screening tools. We have a lovely case study that's been prepared for us by our colleague Sazi Makumbe, who has worked together with SAF AIDS. Well, she is from SAF AIDS, and she's worked together with PATA to create this case study. So Sazi, are you able to unmute yourself and share your screen?
Yes, thank you, Maggie. I'm trying to share the screen.
Okay. Could the ECHO team just have a little check at Sazi's permissions? Oh, there we go.
Right. Are you able to see the screen?
I am. So in Cheryl's presentation earlier today, we heard a little bit about using risk-based screening tools. And we learned about a recent review and meeting that WHO convened to really bring together country experiences and published evidence about using risk-based screening tools in the context of HIV testing. So Sazi has prepared an example of her work and is going to prepare that, but I also did answer a question in the chat that I thought was really helpful. So we know that some tools really are designed to screen people in for HIV testing services to increase the number of people that are tested. And some tools really are designed to screen people out, to maybe to increase yields or to limit the number of HIV tests that we use. So here we're going to learn a little bit about Sazi's work, and this is a tool that's similar to the Bandison tool that we learned about, and that is used to screen children in. Sazi is going to talk a little bit about next steps for the tool, ways that it's been expanded, perhaps some of her experience with tool validation. So over to you, Sazi. We really welcome you and thanks so much.
Okay, thank you very much, Maggie. I hope everybody can see my screen and that I'm also audible.
You are, it's perfect.
So I'm going to present on a screen which we use for a project in Zimbabwe, which is termed Find, Test and Treat 1,000 Children who are 0 to 14 years. And this is a community-based program. So we actually do the screening door to door within the community. So it's different. We're not administering the tool at the facility, but within the community. So as everybody knows, Zimbabwe is a resource-constrained country, and therefore we want to save as much of resources as possible. So we only want to test those children who are who present with a higher risk of being HIV positive. We actually work with the community-based cadres, community case finders, whom we call CCFs, as well as community testers. These are people who are chosen within the community by their leadership because of their conduct in the community. They command respect. And then we give them a 5-day training in SAF AIDS so that they understand the basic key facts about HIV, as well as their roles and responsibilities in terms of screening the children within the community. So the tool is administered to parents or caregivers of HIV-exposed children. And now I'm showing you the screen with the 5 questions. And as Maggie said, yes, it's very similar to the screen which Bandison also is, which we saw from Bandison. So there are 5 questions which we ask. And these questions really, they are looking at either a child who could have had vertical transmission from a positive mother. So we ask about the parents, whether they are dead or alive. And then the other 3 questions which are coming, they're actually focusing at a child who could be having immunosuppression, which could be due to HIV. And then the last question, this is for children who are above 5 years, 5 to 14, where we ask if they've had any signs of sexual transmitted infections, such as vaginal discharge or rectal discharge. And then how do we identify the children who to screen? Because we're not going to all homes, but we go to specific targeted homes. So the first, we work very closely with the health facilities within the community. So we look at the exposed infant register, where we are given children who were delivered at the facility and they were HIV exposed, so that the case care finders who are trained can follow the children and go and administer the VAT tool. We also use the lost to follow up register from the health facility. And we work very closely with the district nutritionist for any children whose weight is below what's expected, because again, that could point to immunosuppression, so that we can administer the tool. We also collaborate with other community cadres, apart from the case care finders, who are specific to our program, FTT 1000. But there are other community cadres, like the healthcare workers and the community case workers who are attached to social welfare. These ones also visit the homes, but for different issues from HIV. And therefore, these ones cross-refer to the case care finders if they've got any child they think could require device screening. Also, during community meetings with the leadership, they can actually point out to where their children they suspect could actually benefit from our services. And then what have been the successes for this program? After training, the CCFs are equipped and they are well received within the home so that they can administer the tool. And then we've also realized that in the 3 districts where we are working, in one of the districts, the prevalence, the positivity rate for our program was actually higher than that of the district from the ministry perspective. And then the other advantage also is that it is easy to track service provision of those who are referred after the VAT screening, because the CCF will refer to the community tester who actually does the testing within the home. And then so through the registers of the community tester, as well as we are able to tell if the child referred by the CCF got the service. We also use referral slips for easy tracking. However, we also have faced some hardships. The community cadres, they travel a long distance, especially within the community, who are practicing within the community, in the rural area, and within the urban center. So within the rural communities, the households are very far and they travel for a long distance. And at times, they have to repeatedly return to the homestead because they might find the necessary person not there to be able to administer the VAT tool. And then also there's been a long turnaround time between the screening and the actual tests, because the community testers are fewer than the CCFs. At times you find that, especially within the urban setting, you are given a name from the health facility, from the lost to follow-up register. When you get to that home, those people have actually migrated, they've left where they were staying, they've changed addresses. So at times they are not even able to find that child, and that child might continue missing. And then in other limited households, some caregivers are not able to allow the CCFs to administer the tool until they get permission from the biological parents, who may be away for the one reason or the other. And then what recommendations do we have after using this tool? The first one is to make sure that we have adequate community case finders to administer the tool, so that they cover a smaller radius and see more children. And also, it's important that there are correspondingly enough community testers so that there is a long turnaround time between VAT screening and the actual testing. Because people have even talking about children dying because they were initiated on athlete. So after somebody's been screened, we really want them to be tested within a short space of time and then be referred to the health facility for initiation. And then also it's very important to track the service provision, so that that missing child whom we found, we won't miss again because of our tracking loopholes. And then from the community test, from the case care finders, they've also recommended that maybe it might be necessary for us to add 2 extra questions. One, to know the HIV test of the biological parent, if they are willing. As remember, we use a rights-based approach, and therefore this is voluntary information if they are willing to tell us. And then lastly, it's also important that we ask a question, when was the child last tested? Because at times, the child could be waiting for their results. And so we don't have to test them until maybe they get their results. Thank you very much.
Thanks so much, Sally, for that presentation. Before we bring in our discussants, Dr. Tassi from the Ministry of Health in Uganda, and our colleagues Catherine Nyok and Roland Vanderven from EGPAF, I'd like to just ask you if you've had any experiences around the use of the tool for younger children or older children. In one of your slides, I noticed that you'd proposed including a question on STI signs and symptoms, and for older children, I assume. And I wondered what were some of the sensitivities or concerns that your team had, especially given that you noted that the tool was administered to parents. So I know that here in this session today, we're really focusing mostly on younger children, and perhaps at another future point, we might focus on testing approaches and differentiated services for adolescents. But here, since we've talked about it, I wondered if you might speak a little bit to that. Thanks so much. And then over to our other colleagues.
Hi, Maggie.
Yes.
Okay, so I can respond now?
Yes, please.
Okay, thank you. Yes, definitely there's a lot of sensitivity around issues of STIs, especially when we deal with adolescents, because now we are testing up to about 14 years in our program. Some of them, they will not tell you the information there and there, and they may actually require somebody who is slightly their age to ask these questions. But because the case care finder is somebody who actually commands respect within the community where they are operating, and also it's somebody who has been taught how to approach these young people when they're asking sensitive questions. Some will answer, but some will opt not to answer. Like I said, we use a rights-based approach. Nobody will be forced to answer if they are not willing to answer.
Thank you.
But for some, we've been able to get some answers from the young people, especially if the case care finder is of an age which is not too much far from these people.
And have you and your team yet done any new validations of the tools as you have introduced additional questions?
We have not introduced additional questions, but this is a proposal which this is a recommendation. Otherwise, those 2 questions we haven't added them yet.
Thanks so much. That's really helpful. I know that also there are partners and others who are available to support the development and evaluation of tools and of new questions, if that's something that your program is interested in doing. I'd like to welcome our colleague, Dr. Jeffrey Tassi from Ministry of Health in Uganda. Dr. Tassi, could you unmute yourself?
Yeah, sure. Thank you.
Dr. Tassi, Uganda has piloted and validated screening tools for adults and children. And so today we're talking a bit about children. And I thought maybe you might share with us some of the lessons learned from the process of introducing tools and validation. Where were there some successes and where are we missing people? Thanks so much.
Thank you very much. So I need to get the name right. Martina, for this opportunity. Yeah, once again, I'm Geoffrey Tassi from Uganda. I work with the Ministry of Health in the AIDS control program, and I am the officer supporting HIV testing services. Yeah, very good question. I'll just speak probably broadly, and then if there are any specific questions, I will respond to them. So quickly, again, I've been following through the presentations, and I see a lot of similarities and cross-cutting issues. So a couple of years ago, we started on the processes of targeting our testing, our efforts to target our testing, just like any other country, because you know very well that most of the countries, especially here in sub-Saharan Africa, we have reached saturation levels, but again, there are populations that still present with big testing gaps. And one of those is the children, but also the adolescents, as well as men. So we developed a screening tool for children and adolescents. At the beginning, it was combined, younger children and adolescents. So it was covering the age range, 18 months to 19 years. And that was kind of outrageous. So we started with the pilot, then we went to a scientific validation. Along the way, of course, we learned that when you lump those together, then it's a bit of a problem. So in the second phase of the validation, we then focused on children 18 months to 14 years. So the 15 to 19 adolescents are now part of the adult screening tool. So what are some of the quick lessons that we've learned? Because after the validation, then we've been in the process of rolling it out, especially starting 2020. Yeah. So one of the big lessons, again, that we saw with this screening tool is that OPD is actually the main entry point for children, because as we use the tool, we realize that most of the children, positive children, were actually identified at OPD. It even presented very high sensitivity at OPD. So OPD, that's the outpatient department, should be the biggest target for children. We trained health workers do the screening, and again, majority of these are lay testers. But also the other thing we did, we trained the healthcare professionals, the clinicians, as well as the nurses. So each of them at their station have a copy of the screening tool. So the tool was able to reduce the number needed to test to identify a positive from 61 to 43. That was a very significant drop, dropping from 61 to 43, presenting about 30 to 40% drop. The other lesson that we learned here is that at first we had a challenge with documentation, because people would screen, health workers would screen, but there would not be any evidence that, of the people screened. So at the end of the day, we had a problem with the denominator, yeah, as well as our numerator. So what we did at the national level, we revised the outpatient register. And so we have included a column for eligibility screening. So this cuts across children and adolescents. So at every OPD attendance, people are screened. Children are screened, adolescents are screened, and adults are screened. So at the end of the day, you are able to review the performance, how many attended OPD, how many were screened, how many were eligible, and then you follow through the cascade to how many were tested. So that has been a very huge lesson, contributing to people being able to adapt the tool. Of course, We also see increase in numbers, absolute numbers of children are tested, identified as positive. I just want to warn some of the colleagues here that during the pilot, we actually saw our positivity among children do raise from below 1% to about 3.5% in some settings. Now, our epidemic is actually heterogeneous. There are places with a higher burden, higher prevalence than others. So it cannot be uniform across. So during implementation, we are seeing that in some areas, you screen and really screen very well, but you still have positivity of 2%, 1%, yeah? And of course, some people, that's a problem. But for us, because we've been following through the trends, that's not a problem at all. Because of course, as you screen, as you identify more children, fewer and fewer children will remain out there. So the yield will not necessarily keep increasing like some people might actually assume. The other key lesson here is that screening is best done at first contact. So because we have integrated the tool at the different entry points for children, including the young child clinic, that's where immunization is done, the outreaches in the community, all those community workers and vaccinators are able to use the screening tool. So because we've done that, we've seen that missed opportunities have actually are reduced. But the point I was trying to make is that screening is best done at the first contacts with the child, yeah? If there's a missed opportunity at the first contact, that is at the OPD reception area or triage, then the clinicians are able to screen as well. Because at every point of care, you have the screening tool at the outpatient settings. Just before I conclude, one of the other things maybe that I just want to speak to is that as we validated the tool being 88% assistive, it meant that you screen out about 12%. Now, what happened this 12%? And that has been one of the biggest discussions here in the country. Today we are discussing pediatrics, but we also realized that the adult tool actually was screening out about 90.3%, 10.3%, because it's 90.7% assistive. And among those that were screened out, the positivity was about 1.5%. Now, back to the children. What happened, these children that we are screening out? So I just want to say that in Uganda, we have an HTS optimization plan. So screening is one of the key ingredients in the optimization plan for HIV testing, but also we have intensified our index testing for children. So what we've done on the ART care card, or the mother's file, or the father's file for that matter. So the care file at the ART clinic, we have included what we call a family tracker. So this family tracker, you are able to capture all the children and partners of the client, yeah? So as you're screening at OPD, you are also intensifying the index testing, index client testing, index case finding for children. The other thing that we are trying in a pilot mode now is the oral screening, caregiver oral screening for children using the Oral Quick test kit for mothers to screen the exposed children. So this is another form of index testing, but now it's the mother who's doing the screening. So we are trying out this, and we think that this is going to be very, very useful in reaching out those other children that would have otherwise not reached out to, or would have missed, because they may not come really soon. Yeah, sure. Yeah.
No, it's really excellent to hear you talking about how you are using a variety of strategies and approaches here together. So not only risk screening tools alone at intake, but combining that with family-based index testing approaches. It makes so much sense. And I think that we really have so much to learn for you. But because we are short on time today, I'm going to pass over to our colleagues from EGPAF, from the Elizabeth Glaser Pediatric AIDS Foundation, Catherine and Roland, to share a bit about their experience supporting ministry to implement risk screening tools in Tanzania. I'm wondering if you can speak a little bit about how you expect the performance of tools to change over time. And I think Jeffrey really touched on this, that we cannot necessarily imagine that tools will be a magic bullet for dramatically increasing yield, especially as we look into the future. Talking a little bit about how these tools are used complementarily with other services. So over to you, Catherine. Thanks so much.
Thank you, Maggie. My name is Catherine Nko, and I'm from Elizabeth Glaser Pediatric AIDS Foundation. So we expect that with the scaling up of the different programmatic components, such as the shared family-based index testing and other interventions that are improving the prevention of mother-to-child transmission and early infant diagnosis, we discussing this from the point of young children, whom in this population we expect that most of the transmission will be vertically. So once EID services and PMTCT services are scaled up to a full extent, we expect a fewer number of children to be identified through the use of the risk screening tool. Those who will be eligible will decrease exponentially because of the scaling up of the EID and PMTCT services. But also with the rollout of index testing, we expect also fewer children to be identified, since with index testing, you follow up to test the biological children of women who are already HIV positive. So we expect the number of children who will be eligible again to drop compared to when these services are not fully scaled. And the transition won't be sudden. Definitely it will be stepwise, but we expect to see the proportion of children who are identified HIV positive through index testing will be increasing compared to those who are identified after being screened positive using our screening tools. And we also, looking at the experience that we've had in Tanzania, we have considerably seen that the tool was useful in increasing the yield initially. As time goes, we are seeing the yield decrease steadily. And as the previous speaker just said, that we expect the tool to the yield to continue decreasing because most of the children will be identified by then. So it is true that with time, we expect that the screening tool to not be as effective in identifying, if we term yield as the effectiveness of the tool, then we don't expect it to be as effective when these other interventions scale up to a point where they're fully being used. And also, when we look at how it has been able to improve identification among pediatrics in Tanzania, testing among pediatrics was low initially. So with the introduction of the screening tool, we've seen a pickup in numbers of children who are being tested, because now once they're screened and found eligible, they cannot be left out without being offered HIV testing services. So it has been very instrumental in promoting HIV testing among children in both the inpatient departments and the outpatient departments as well. So it has been very useful in promoting testing among children.
Excellent. That's really wonderful to see that it is useful for promoting testing, something that we want to do. May not be so useful moving forward in having a dramatic increase in yield or positivity. We got some interesting questions from the audience or the participants here in our session today. We wondered what age groups were generally included. I believe that Sazi spoke about children through age 14, so that would be younger adolescents being targeted in the screening tool application that she spoke about in Zimbabwe, but perhaps others could share about the different age groups that are targeted. So perhaps first our colleagues from EGPAF, and then over to you, Dr. Tassi.
So like Salvi, we have all our screening tool for pediatrics is for children aged less than 15 years. So it's 2 to 14 years of age.
Yeah, so the Uganda screening tool, ATASI here, is 18 months to 14 years, because we start doing the rapid test at 18 months. Yeah, so 18 months to 14 years. So we have the younger adolescents up to 14, then the 15 to 19 adolescent group, because they somewhat had characteristics close to the adults. So we screen them with the adults. Yeah.
Thanks so much. And I also wanted to note that there's some interest in the comments to have a look at some of the tools. And so I might invite Sazi, Dr. Tassi, and our colleagues from EGPAF to share with me any materials that we might package up and include in the box folder for dissemination later in the week. Thank you so much for all of your participation. I'm going to hand over now to Therese, who is going to speak a bit about family-based index testing, and most specifically to the West and Central Africa experience. Now, I'm going to hand over to Therese, but I wanted to extend our apologies that one of our participants for this session is unable to join. So it's going to be Therese, and we're so thankful for her flexibility in covering the session. Therese, over to you.
Okay, thank you very much, Maggie. I will do my presentation in French. Je m'excuse vraiment pour le collègue du Cameroun qui n'a pas pu se joindre à nous à cause des problèmes de connexion.
I would like to present the excuses, the apologies of my colleagues who were not able to join us. West Africa and Central Africa are covered by UNICEF. And I will give you a brief view of what is happening in Cameroon in this webinar. I will try to share my screen with you.
Hi, Therese, we can see your screen now.
Okay, merci beaucoup.
Thank you very much. As I was saying, I am going to talk to you about the indexing and diagnosis among the family. First of all, I'm going to talk to you about family testing. And I'm going to share with you the document that we have developed regarding family testing. And I'm going to talk to you about the monitoring tool, our dashboard, as well as progress in the region, and give you the Cameroon experience as well. I'm not going to delay on this page. The family testing has proved to be very efficient, and it is a high-yield strategy to identify children often missed through the health system. When we are talking about family testing, as you know, we emphasize on the adults and the adolescents. And the children, the adolescents, must be tested. So we offer testing to the whole family, to the husband, the wife, and the children as well. There are 4 components of family testing: identification of family members of a person, adult or child newly diagnosed, or in HIV care and treatment services. We also offer HIV testing to family members with unknown status. And this is important. And the communication of results in an age-appropriate manner to family members, as well as facilitating disclosure, is extremely important. The operational guide that we have developed to enable our country to proceed with family testing is like this. It has been rolled out in 12 steps. We will get into the guide a bit later. I only have the English version of this operational guide. We need to examine how all stakeholders are taken care of. What is the gap? How many adolescents and children are not receiving treatment? And we need to talk about testing that is happening in the whole country. We need to analyze, first of all, the situation. And we need to develop a strategy of communication and undertake a national consultation in the context of testing to see how we are going to proceed with family testing. We also need to leverage resources to see how we can accelerate family testing. We need to build capacity of all the actors that are involved. And as I was saying, how we can proceed with family testing in using various approaches. Also foster integration and multi-sectorial collaboration. And what is most important is to give the relevant treatment to the family, but also to communicate appropriately with the family members. We need to, of course, exchange knowledge. There's also monitoring and evaluation.
Voilà. Ça, c'est le document, c'est l'aperçu du document.
This is a brief overview of this operational document. The monitoring, we developed a questionnaire that comprises 12 steps to give the country the opportunity to give us the progress that has been made. In the first quarter of 2020, and also in the third quarter of 2020, we did a follow-up. There were a set of inputs that were sent online, followed by an analysis. And also, we need to take care of the people who tested positive. We need to have quantitative data on the cascade of those who have been accepted, tested, to those who are positive, and link them to care. This is a brief overview of our dashboard on the national rollout of family testing in West and Central Africa. The green, it shows that the country has good results with regards to the steps. Orange color indicates that the interventions are ongoing. And the red indicates that interventions have not started yet. For the second and third quarter, it would be the same thing. The country, with regard to the 12 steps, will inform us, the country will inform us of the progress achieved. The color green encourages us in the sense that we can see progress is being achieved. So progress on the 12 steps between the first and the third quarter. Most countries have made significant progress on step 8. And we have been able to deliver family testing with a package of differentiated HIV testing services. Also, progress with regards to step 9, which is foster integration and multi-sectoral collaboration, and step 10, activate family testing in focus regions. Most countries have not made progress with step 6, which is leveraging innovation, where 16 countries still have not started and only 4 have achieved it.
16 pays n'ont encore rien débuté sur ce step. Il n'y a que 4 pays qui vraiment...
Only 4 countries, as I mentioned, have achieved the necessary innovation in the area of testing.
Les pays qui ont fait vraiment beaucoup de progrès entre les 2 trimestres sur les 12 étapes, c'était le Bénin, le Congo, le Niger.
Between first and third quarter, the countries that have made most progress on the 12 steps are Benin, Congo, and Niger, having achieved 4 additional steps in between the reporting periods.
Ici, vraiment, on doit avouer que nous avons beaucoup.
Well, this is the dashboard of the national rollout of family testing in West and Central Africa. You can see the average acceptance rate. The average of acceptance rate for the testing is only 93.59%, and average of positivity rate 3.43%, an average of treatment initiation rate 97.28%. On the left-hand side, we can see a map that shows the average coverage rate, which is 68.69%.
De taux d'acceptation, 98% d'initiation au traitement pour les personnes qui ont été découvertes séropositives. On va partager la présentation.
We will share this presentation with you. Here, this is a quick analysis of the quantitative data. There's only 7 countries in the first quarter that provided quantitative data, 12 for the second quarter. So we need to contact these countries so that we can have a better rate of acceptance. We have approached quite a number of people, and we saw that we received a good rate of acceptance of 33%. In Chad, we can see that the acceptance rate is at 23%. Maybe that's because there is a good level of communication. And we also see that there has been progress from the first quarter to the second quarter. We are approaching a bigger number of people. And there are more and more people who are interested in the treatment, in the testing and in the treatment. And of course, our treatment that is for the children and adolescents. Of course, there is also a monitoring program within these countries. And the countries are working on the gathering of data and how to treat, how to analyze these data. Because that's how we really get to know the results and find out whether children are receiving the necessary care. I thank you very much, and I also thank the colleagues who assisted me, the colleagues from the country, from the regional offices, from UNICEF, and from UNICEF HQ as well, who assisted me. Thank you very much. This was experience sharing at a regional level. I wonder if I could give you a few country experiences.
I think what I'm learning from everything you've summarized is that we probably need to create space and time to discuss all of this in more detail.
Okay.
So I'll take this back to our WHO team to discuss how we can follow up on this important topic in the upcoming webinars and ensure that this is discussed accordingly. But thank you so much to you and all the UNICEF colleagues for really contributing to this really important summary.
Yeah, thank you very much for giving us this opportunity to present this work. Thank you.
Thank you very much. So I'm just trying to share my slides. So if our ECHO colleagues could allow me to share slides. Perfect. So I think the webinar today has really highlighted a lot of important questions that remain for all of you on the ground. And I think that we really hope that if we haven't been able to cover everything, that we provided some useful insights for the work that you're doing at the country. We've heard very clearly how WHO policies continue to support combined testing approaches, and I won't go into the detail, but it's very clear that those policies need to include robust infant testing algorithm, needs to have appropriate use of HIV testing kits and implementation of community-based testing when possible. We need to focus on key entry points and really target our approaches to the epidemic context. And we have provided some tools that could help you to do that. But we also acknowledge areas where we continue to need some more information and some more experience from the ground so that we can further strengthen our policies. We heard very interesting perspective from countries in terms of implementation of the infant testing algorithm. We've heard about the birth testing in high-risk infants from Zimbabwe, which seems to be promising, but I think that Angela made it loud and clear that the 6 weeks testing remain critical, and that's something that we should never forget when we implement birth testing programs. We also heard from Kanchana that there's more work to be done in ensuring that the infant testing is implemented after the 6 weeks and continue to be implemented after the 6 weeks testing, with the 9-month testing in particular, but also with the final diagnosis. And lastly, we heard on the point of care implementation, how point of care really improves turnaround time, improve the link to treatment. But it's important that we don't forget that the lab network remain important and needs to be strengthened, particularly for those settings where point of care might not be available yet. And as we do scale up point of care, stock of reagents, mentorship, and really support human resources, it's really going to be important. We've heard very interesting perspective from Tanzania and Uganda on the use of risk-based screening tools. We've heard that overall they're not a magic bullet, but that there are opportunities, for example, to really promote testing in these settings and certainly to increase yield in some places. We, however, have heard from colleagues that approaches might need to be changing over time, particularly as we scale up PMTCT, EID, and other testing approaches. And so important to really think about these screening tools in a very dynamic way. Lastly, we heard about family-based testing. We've heard about the critical steps to be undertaken, how building the capacity and fostering integration are critical elements to that. That we might need to focus on some regions that should be prioritized. We've heard that from West and Central Africa, and that we've seen some monitoring tools and dashboard that can help us in implementation and monitoring progress. So I think that clearly there's more to be discussed in all this topic. We continue to engage with you, and so please let us know if there's anything in particular that you'd like to hear more about in the next future. We know that many of you are currently very busy in building back better as a result of the restrictions that happened during COVID pandemic, and some of you might be going through that wave right now. But it's critical that we remember that testing is an important cornerstone of a strategy that includes many other interventions that needs to be developed once the family comes back to the facility. And we need to maximize that unique opportunity to really provide the HIV services that this family needs. Just to let you know that we are in the process of updating our WHO webpage, where you will find a lot of the material we referred to, both in the AIDS-free toolkit, which has been the place where we have really stored a lot of the documents that we referred to today. So please let us know if you're struggling to find the material that we referred to. And lastly, really want to remind you that there are a number of webinars that are planned for this year, and these are the dates and the topics that we plan to address. And the next one in particular will refer to the updates in the clinical recommendation that will include viral load testing algorithm, as well as some additional elements that relate to clinical management more broadly. So I'll stop there, and on behalf of all my WHO colleagues that are on the line, really want to thank all the speakers and the partners that have contributed to this webinar, and all of you participants who have been so engaged and so active in the interaction today. We really appreciate it, and we hope to see you soon on our webinar in the coming months. So thank you again, and have a good rest of your day.